ones. Over the next 2 weeks, we're going to put the spotlight on a
Hold
lot
on,
of our
I'm not seeing it. Hold on. Okay, sorry, now go.
heroes, like the team you're about to see. For the last 10 months, healthcare workers have been at war. We know that. They are tired, they are stressed, they are often on the brink themselves. And it's at those tough moments at JPS Hospital in Fort Worth that the pastoral team brings the faith so our frontline heroes can keep it themselves.
What have been your hardest days?
Losing someone. That never gets easy because, sorry.
Life inside the JPS COVID unit is understanding that.
Go ahead.
Yeah, it's working fine.
Yeah, cut it and put the quality placard back up so we're not broadcasting anymore.
1. Dr. Weber, you're live with the Quality Committee.
Hi, this is Charles Weber, bringing you the Board of Managers Quality Committee meeting, 1500 hours, Thursday, the 4th of September, 2021. Any citizens wishing to talk to the committee? David, Jeffrey?
No one's.
Okay. And the next one I have is number 3, which considers the minutes.
This is Zim. I move to approve.
Ms. Dorothy,
Change that Amanda put out.
Yeah, there's one change, and that is Amanda was present, but she's not listed here on the attendees.
okay, I second it with the addition of Amanda's name being added as addition.
All right. Is there a second to that?
That was a second.
All in favor, please say aye.
Aye.
Those opposed say no. The next one I have is approval of Tarrant County Hospital District policies and/or plans. First one up is PC 2600 adoption. Dina Dan.
Dina, you're muted.
Muted. Oh, I was saying so much good stuff on mute there. I'll try to repeat that. Good afternoon, everyone. Thank you for allowing me to present policy 2600 adoptions for approval from the board. This policy was updated and modified around language. We updated some outdated language around terms such as illegitimacy, and we updated pastoral care to spiritual care. We also updated our adoption agency list from 2009 and updated it to 2021. There was also some grammatical and some punctuation updates and changes made for this policy. There's a procedure attached to the policy for the board to review. I would like to ask for approval for policy PC 2600 and adoptions, please.
All right, everybody's heard Dina's presentation.
This is Dorothy. Move approval of 2600 policy PC 2600.
Is there a second?
This is Zim, second.
Hi, Zim. Any discussion? All in favor, please say aye.
Aye.
Those opposed say no. Motion passes.
Thank
Number
you.
two. Thank you, Dina. Number 2 is the 2021 coffee plan. Rob, you're up.
Thank you, Dr. Weber. And I thank the board for the opportunity to present our 2021 QAPI plan. This is a regulatory requirement to present a plan each year. I want to give a tremendous amount of credit to Allison Windus for what was a really fantastic rewrite of our QAPI plan. You'll all be glad to know that she reduced it from 17 pages to 6, which is a fantastic accomplishment all on its own, and it made it much more pithy and much more relevant to the working of this organization, and much more of a catalyst for actually focusing our quality efforts for organization. Also contributing significantly to this rewrite was our quality council, co-chaired by both Dr. Fromm and Jesse DeWard, our executive director of emergency services, whom you met last month during the emergency medicine presentation. So I want to just focus you on a couple of items with this. I won't read it all. I actually did that for the medical executive committee. They actually liked that, but I won't take the time to do that here. But I do want to focus the group on the second page, which are our 2021 specific goals under the QAPI plan. These are different than our organizational goals or our AIP goals, but they are additional goals that we want to put attention to and that we want to hold ourselves accountable to for the coming year. One is in care transitions, where we have a very dynamic multidisciplinary team headed by both members of Laura Burnside's team, as well as one of our performance excellence consultants, Terry Savage. working to drive improvements in that area. And then the second is around hospital throughput, which remains, of course, a huge challenge for us at JPS. I also want to focus you on page 3 to the specific responsibilities of the Board of Managers in the governance of our QAPI plan. So I will read through the first 2 paragraphs here, just so that we're all clear about the governance here, because that is a huge responsibility of the Board of Managers for making sure that we drive quality care here at JPS. So under heading number 5, governance, the JPS QAPI plan incorporates robust performance improvement into a comprehensive patient safety program that is ongoing and demonstrates measurable improvement in the quality of care and safety of patients. The Chief Executive Officer, through the Chief Medical Officer and the Chief Quality Officer, drive the QAPI program in collaboration with the Board of Managers, leadership team, organized medical staff, and employees of JPS. In order to ensure organizational alignment and goal congruence, the QAPI plan is operationalized through JPS's clinical and operational infrastructure. So the responsibilities of the Board of Managers are, number 1, responsible for support of performance improvement and patient safety by establishing the strategic direction, overseeing the prioritization, assessment, design, implementation, and ongoing monitoring, allocating resources, and providing supportive infrastructure, ongoing awareness and evaluation of their roles and responsibilities. Number 2, develops, executes, and enforces a plan, a systematic process whereby the quality and safety of patient care and services provided are prioritized, measured, evaluated, and improved. And then delegates, number 3, delegates responsibility to the quality committee, which is this committee, a subcommittee of the Board of Managers, the medical staff, and senior administration, the responsibility and accountability for the operations of the QAPI plan. So with that, I will ask approval for our 2021 QAPI plan. And before that, of course, I'll be happy to answer any questions.
Anybody got any questions for Rob? Pretty silent group. Any thoughts, comments? I agree they did a pretty good job of reducing it down to 6 pages. Can you hear me, Rob?
Yes, I can.
Okay.
Thank you.
The only
and Allison's on the call. I'm sure she thanks you for your kind words as well. But we do need a vote on this, I think, though.
Yes.
This is a move for approval.
Is there a second?
Second.
Is that a DT?
Yes, sir.
Discussion. There's only one change that I would ask you to make on the QAPI calendar 2020.
Yes.
Down at the very bottom, it has human resources, staff competency. It's got Pia Walker. Does that stay?
Oh, you're right. Thank you. We'll make the change.
Okay. All right. No discussion. All in favor, please say aye.
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 Those opposed say no. I dropped my notebook, so give me a chance here. Rob, that passes, so good.
Thank you, sir. Appreciate it. Thank you to the board.
Oh, man. I lost my minutes. Hold on. Okay, the next one is consider performance improvement reports updates not requiring committee action. First is patient experience, Laura Burnside. Laura there?
I am here.
Welcome back. I'm glad you're better.
Yeah, no, thank you so much. I appreciate the delay in my second report. Thank you for having me here today. I'm honored to be here and talk about our patient experience organizational goal updates so far this year. You go to the first slide for me, please. This is our organizational goal for our inpatient unit and units. And as you know, our goal is to achieve the 75th percentile in 6 of the 9 HCAHPS dimensions. And just as a reminder, HCAHPS does measure us against every adult hospital in the country. So to achieve the 75th percentile nationally is really a reason to celebrate. And it puts us, again, it puts us at the top of the country. As you can see, we're achieving 4 dimensions right now in the top quartile. And we continue to work very pointedly and very diligently to move the needle for those dimensions. I do want to draw your attention to a couple things. Rob mentioned the care transitions multidisciplinary group that we have in place. If you look at the dimension of care transitions on the right-hand side of this slide, you can see as of March 31st, when we ended our AIP year, we were at the 15th percentile in that dimension. And we, through the hard work of that group, have moved that to the 23rd percentile year-to-date fiscal year. So a lot of hard work has gone into that. And while we still have a long way to go, we are on the right track and we are seeing early results on that.
Laura, what is exactly is your definition of care transitions?
Well, it's actually the Center for Medicare and Medicaid Services definition of it, and it's takes into account 3 questions. The first question is: the staff took my preferences and those of my family or caregiver into account in deciding what my healthcare needs would be when I left. The second question is: when I left the hospital, I had a good understanding of the things I was responsible for in managing my health. And the third question is: when I left the hospital, I clearly understood the purpose for taking each medication.
Great, thank you.
The third, or the next dimension that I wanted to draw your attention to is really for recognition, and that is the communication with physicians dimension. And that includes questions that relate to explanation, listening, and courtesy and respect shown to our patients. And as we ended our AIP year on March 31st, we were at the 78th percentile. So it was very strong performance, but they have improved that even more this year at the 82nd percentile. Any other questions on inpatient?
Laura, this
Yes.
is Reverend Emerson.
Hi, Reverend Emerson.
Can you explain just quickly that number on the percentile rank? I mean, when you see a 23, is that high even though it's 23?
Is this the score, the top box score? No, not, and they're different for each of these dimensions.
Right.
And going forward, I can actually include what the top box percentage is so that you can see that. The care transitions dimension is really, it's right around 50% for us, meaning 50% of the time we hit the mark with our patients on those 3 questions. And that's an average. We were below 50th percentile at the 50% positive top box score at the 15th percentile. So it's slightly higher than that now, but it still has a long way to go.
Do we have any ideas or suggestions how we address that area, or is it one of our tough areas to move?
Yeah, it's actually a tough one nationally, but we do have the Care Transitions Multidisciplinary Committee that is very active right now. There are pilots happening throughout the hospital. Currently T11, which is one of our med-surg units, has a pilot running, and all of our nursing team, they are asking our patients right when they get to their rooms upon admission, tell me what's worrying you the most about going home. And so through tactics like that, we're able to identify what some of the concerns are for our patients before they discharge. And that way we're making sure that they understand what their aftercare looks like when they get home, and they can actively participate in that, and they understand their medications. And we're seeing actually a tremendous, this has been really interesting, but through that committee's work, we're actually today seeing fewer comments that relate to not understanding those things that fall into that dimension when we make our discharge phone calls. So what I mean by that is we call every patient who discharges from the hospital, and fewer times now they are mentioning questions about those areas or concerns about those areas. So we know that not only is the data showing that we're improving, but our comments coming back are also showing that and reflecting that.
Okay.
Good.
Okay, so we're making progress. You're very welcome. Thank you. On the outpatient side, we measure this one a little differently because there's not a percentile ranking for this. It's a different survey methodology that is not required through CMS. So if you'll go to the next slide for me, these are actual percent top box. So, our goal, our target is to reach an average of 63.6% top box. And you can see where we were in March as we ended our AIP year and where we are fiscal year to date. And I cannot say enough good things about the work that's happening. This includes our face-to-face visits and our telehealth visits. And as you can see, almost every single question has improved significantly for our community health team members and our patients. So it's a win-win. Win for our team, win for our patients. Any questions on that?
Laura, may I go back one page?
You certainly may.
Would you comment on how it fell down a little bit on ease to get an appointment?
On the outpatient side?
Yes.
Okay. So your question, tell me your question one more time.
Well, it looks like that we fell down just a tad on easy to get an appointment for the clinic.
Yeah, and I think over the course of the last few months, what we have talked about, and I know Joy was here talking about this as well, where we were adding more additional staff to the call center so that we could get the calls answered faster than what we were. This also has, so that's been a challenge. This has also been through scheduling of COVID vaccines and also appointments for the clinic. And so we have seen that drop. So we are actively working with the call center to determine ways that we can improve that for our patients when they call through. So we actually have a weekly meeting with them now.
Okay, one of the reasons I asked is at the last quality meeting, Dorothy DeBoe asked me specifically, how long would it take, let's say, a 65-year-old to get an appointment for a new clinic visit if they were coming in to try and get the COVID-19 vaccine?
I cannot answer that question for you.
Okay.
I don't know if there's someone on the call that can, or we can get that information and get that back to you as the board.
So Chuck, this is Rick. How you doing?
Hey, Rick.
Hi. So this is a loaded question, especially in COVID, because as you know, we had to cut back the number of elective appointments we have for health, regular health appointments, and we are half staffed in the clinic, and so automatically people are going to have a much harder time getting an appointment just for wellness sake. And we're only doing urgent and emergent cases. So I suspect a small dip in the satisfaction of getting an appointment in that arena. As far as the vaccines go, I think Dr. Alawi and others are really working hard now to identify high-risk patients in the 1B category for getting them an appointment, doing texts, emails, and multiple ways of trying to get those high-risk patients into the clinic to get a vaccination, which I think is probably a little bit different than this this questionnaire on the age cap questionnaire.
Okay, great.
This is Dorothy, and I have a question on some of just what you said. What is you probably can't answer this, but what are the plans for us to open our clinics so you can do well clinics? Because if you're not doing that, then we're going to have more patients coming into the ER. So I know other providers are now opening back up. And so do we have a plan to open back up more face-to-face clinics?
Yeah. So Dorothy, if I can answer that for you, we are opening back up our clinics. We brought them down temporarily with this most recent surge, so we're very flexible up and down. As far as our third next available, we are doing a number of appropriate telehealth visits. So our third next available is not far out. We are touching those patients. We are also doing some face-to-face as we are permitted to do based upon social distancing and making sure, that we're meeting all of the requirements as far as safety for our patients. But we are expanding the face-to-face. I can get back as far as what third next available, but we've been great with the telehealth and maintaining that contact with each of our patients in the community.
Okay. All right, thanks. If you would, because I know that means we have to change some of our how folks come in, just like at my provider is they send me a notice and here's some things that they've changed. So I know we need to change some things if they're going to go back in and do face-to-face.
Yeah, and we have done a lot of that really based upon you giving us some of what you went through with, possibly waiting in your car, but we're also aware when they may be bringing family members, we've asked them to, when we make the appointment, whether they will have a family member that will be accompanying them so that we are managing our waiting areas and ensuring a safe environment for our patients.
Okay, all right.
So Joy has done a great job and she would be glad to come back and speak to what's going on in the outpatient setting. Thank you.
Thanks.
And this is Dr. Alawi. Just to add to that really quickly, we are able to see new patients as telehealth visits. So though they might not be able to make it into face-to-face visits, we are able to see them at least as telehealth, whether it's by phone or video. And so that's, once they've seen us, we can get them scheduled for things like labs and vaccines and anything else that they need. And so we are doing our best to get these patients in any way that we possibly can.
Great, thank you. Anything else, Dorothy?
For me.
I don't hear anything. Okay, Laura.
Okay, thank you. And I can't say enough about the work that's going on there. It's a lot of it, and our patients are responding well to the changes and the work that's happening. The next slide are the other areas of the hospital that we measure. And so I won't spend a lot of time on this unless there are specific questions, but these are all of the metrics that we're tracking that are not organizational goals, but they're things that we track. So behavioral health, our outpatient surgery, and our emergency services and urgent care.
Okay.
So I will keep those going. The last slide just shows some of the main action items that we're working on. We've mentioned the Multidisciplinary Care Transitions Committee multiple times. We have our next cohort starting for our mastery program next week. And we have multiple mastery programs. This one is just the Patient Experience 101. We've got Dr. Miller and I have been working with Alex Moore on our mastery program. And so we are ready to go and launch that next week. And we're excited about our new group coming through to learn more about the fundamentals of patient experience, but also the definite importance of creating community. And then Dr. Miller and I partnering together on clinician engagement has also been just tremendously instrumental in a lot of the work that we're doing. And I'm very grateful to him and his partnership. And then we're also working with our community health partners on getting access to the provider through MyChart utilization and the partnership that I mentioned with the Access Resource Center. And that's all I have on our data update.
Okay.
Okay.
You want to take on the language services?
I'll keep on going. Yeah, I said I feel like I have this whole chunk of the agenda. Okay, so imagine that you are a Latino patient and you hurt your ankle very badly and you decide that you're going to come to the emergency room for some help. And here's how your ER visit goes. Our team member says, "What brings you to the emergency room today?" And the patient says, "I went to the fiesta, I fell, and I broke my ankle." And the provider says, "Well, how much were you drinking?" And the interpreter turns to the physician and says, "Doctor, we wish to clarify with the patient. You went to the Fiesta grocery store and you fell in the store and maybe you broke your ankle?" And the patient says, "Yes, I was shopping for food." This is the type of interaction that happens to us all the time here at JPS because about 25% of North Texas households speak English as a second language or not at all. And so the need for interpreter services has grown tremendously over the course of the last 5 years. So why 5 years? I wanted to revisit, this was actually one of the first presentations that I gave to you all when I joined JPS. And at that time, we were interpreting 3.2 million minutes a year, and we had completed about 180 translations that year. Today, our last year's data takes us over double of those areas. And so it's really hard to believe how much we have grown. And our team still continues to work very hard to ensure they're providing information and explanation in languages that our patients understand so that they can actually receive exceptional care every time they walk through our doors, whatever their language is. So there is a tremendous cultural component involved in this. It is not strictly word for word interpretation, as you can tell from the example. So our goal is to clarify and ensure complete understanding of diagnosis and treatment plans. So if you will go to the next slide, please. And I'll need you to kind of click through here. So our top communities that JPS serves, when I first joined 5 years ago, it was Spanish, Vietnamese, and Arabic. We have now added Nepali and French, and there's a misspelling there, so I apologize for that. And then why do we do this? First of all, it's the right thing for us to do for our patients. I can't imagine being a patient in a country where I didn't understand their language and not having interpretive services, first of all. But secondly, Title VI of the Civil Rights Act of 1964 does show that we need to improve access for services with limited English proficiency. And then it's also about culturally and linguistic appropriate service standards. The Joint Commission also requires this, and it allows us to demonstrate that cultural responsiveness. You'll go to the next slide, please. So we interpret for about 52 languages and 120 dialects here on a normal everyday basis. And we do that through staff interpreters, video remote interpreting, and language line. We also have taken on the translations from many of the materials where we used to actually send that out. We do that inside. And then we have a qualified bilingual certification program, and currently we have 125 JPS employees who are qualified as bilingual interpreters. And that's not, again, just that they know how to speak the language, but that they medically know how to speak the language, and that's very different. So there's quite a bit that goes into that. If you will go to the next slide for me, please. One thing I did want to mention, when COVID started, we moved very quickly into a call center environment, and our team members right now are handling about 12,000 encounters a month with our patients here internally. And then we additionally use a vendor for the video remote interpreting, and then Language Line offers us many more languages through that as well. 5 years ago, just to give a little bit of feedback, right now, again, I said 52 languages, but 5 years ago we had 44 languages and only 62 dialects, and we're doing 120 different dialects here on a regular daily basis. Yeah, so, you know, and this is interesting and really important because so often in many cultures, preventative medicine is not the norm. So our interpreters help our patients understand how important that preventative health is for their wellness. And without the service of our interpreters, our prevention would be a whole lot lower. And, you know, to Dorothy's point a moment ago, we would have more showing up at the ER, but this allows us to be able to utilize our family health clinics, which is fantastic. There is a tremendous synergy between our diversity, equity, and inclusion team and the language services and patient experience teams. So, you know, again, that goes back to just helping our patients understand, and our care team to understand the cultural elements that go into this. So things like if we had a diabetic patient who stopped taking medications because, you know, they were told they were doing so well, that they still have to take the medications. They, it's not, no, I'm healed after my first round. And so culturally, our interpreters allow that clarity to come. It can be really confusing for our patients as well. And I think I saw Dr. Kamath on here earlier, but if we said we were going to do a cabbage, our patients can think that's a vegetable rather than a cardiac procedure. So we work very hard to make sure there's clarity. And then I wanted to show I think it's on the next slide. I wanted to show you what's happened over the course of the last 5 years, because I think this is really impressive. These are our dimensions of communication about medications, communication with nursing, and communication with doctors. And you can see that in each of these dimensions, we're making some tremendous progress over the last 5 years. And I thought this was really terrific, because as our need for interpretive services has grown, we have done a much better job with our patients in being able to really communicate with them effectively.
I think that's great.
Yeah, I'm really proud of this team. They've done a tremendous job working with our care team on trying to do the very best they can to make sure there's clarity and understanding for our patients and their families when they come through our doors.
Right.
And I'm happy to answer any questions.
I just want to add on to what Laura just well delineated to all of you, how amazing we do this here. As a lot of you know, I came from a very large academic center, and JPS does it much better in the clinics, in the ICUs, on the floors. We just roll this little electronic television, and there's that expert, cheery, educated, and incredibly engaged with the healthcare provider and the patient, ensuring that they understand everything. So this is a huge asset that we have here, and we do it really well. So kudos to Laura and the team for making this work here, because it's exceptional.
Thank you, Dr. Miller.
You bet, Rick. I commend both of you. Anybody got any questions for Laura or Rick? If not, we'll move on to the next one.
Yeah, so part of what we do in my division is not just taking care of the needs of our patients, but we also work very hard to take care of the needs of our team. And I think there's a video that we are getting ready to show of our chaplains. And this was a news story that was actually shown a couple of weeks ago now on a local affiliate. And I couldn't say enough actually about our chaplains. They are an amazing group of people that are so tuned in to the needs of our team members and our patients, and do some of the most remarkable work certainly I've ever seen from a chaplain team in hospitals. And I could not be more pleased or proud of that team. And every single day that goes by, they touch my heart in an incredibly special way, just like our language services team does. But I think, Rob, you were wanting to show this news clip, and I will turn it over to you.
We have seen
there were some questions. Oh, here we go. This is great. So let's go ahead with the news
We
clip,
like to
please.
call them around here the super ones. Over the next 2 weeks, we're going to put the spotlight on a lot of our unsung heroes, like the team you're about to see. For the last 10 months, healthcare workers have been at war. We know that. They are tired, they are stressed, they are often on the brink themselves. And it's at those tough moments at JPS Hospital in Fort Worth that the pastoral team brings the faith so our frontline heroes can keep it themselves.
What have been your hardest days?
Losing someone. That never gets easy because, sorry.
Life inside the JPS COVID unit is understanding that death is now a big part of the job.
That's been a very difficult year.
COVID unit nurses like Josh Knickerbocker and Larissa Harris are drained. Everyone is. Endless 14-hour shifts, an endless cycle of saving and losing lives. And then there's what many caregivers fear most.
the fear that you're going to get it and you're going to bring it home.
Those fears very early in the pandemic led the JPS pastoral team, led by Leanne Franklin, to quickly become a bigger shoulder for staff to lean on.
And when COVID hit, you know, everything was immediately different. And all of a sudden, those who care for people who are in trauma are traumatized themselves.
One of the most difficult days was seeing someone that a lot of us knew pass. And then, of course, it's setting up FaceTime with families and hearing them talk to their loved ones. Certainly will bring tears to your eyes. Kind of a combination of a lot of those things.
Almost instantly, those who always provide the hope now need it themselves. First thing that came to mind for the pastoral team, a place to simply let feelings go. The Tree of Hope was born.
It kind of took on a life of its own. Some of the nurses said they wanted to do it on their own, and so they did their own hope tree on their floors.
A simple birch tree now filled with over 1,000 handwritten messages of hope by those who walk and work these halls every day. And the team found that writing down feelings is often met by the chance to then talk about them as well.
I've had a lot of chats with my pastor, kind of debriefing and talking to the other nurses about their experiences, and unquestionably the pastoral care team has been, you can't even put a number on all the things that they do for us.
Things like the Love Bomb, surprise visits with songs sung to lift spirits, and the Soul Cafe, offering drinks and sweet treats, and a diversion.
It's nice for that moment just to step outside of the patient care and just for that moment just to focus on yourself in that moment and reviving yourself.
A small but mighty team that leans on faith and figures out new ways to help our heroes keep the faith.
We're people of the light, you know, we're people of hope, and we're going to hang on to hope because that's who we are. It's what we do.
The Super One's pastoral team, by the way, consists of 6 full-time chaplains. They have a few part-time. They work with patients and families in addition to the staff at JPS, of course, and their support knows no time limits. They're available for everybody there 24/7.
So I just wanted to bring attention to this incredible team who ministers to our patients, ministers to all of us, ministers to me personally at times, and I'm just so grateful to them, and they're wonderful, wonderful partners in care and provide a tremendous dimension of caring, concern, compassion, and mercy to all of us here at JPS, and so I'm deeply grateful to them at all times, and I just wanted you to get a little view, wanted you, the board, to get a little view of what it is that they do for us here, and receive your recognition should you choose to recognize them. But I don't know if Leanne is on and has anything to say. Okay.
I think she is, Rob.
Okay. All right. Okay. Back to you. Back to you. We'll do it like the newsroom. Back to you, Chuck.
Okay. COVID-19 update. You're up again, Rob.
I am. All right. So, as I do every month, I bring you the current numbers. The tough thing is that the board book is due a week in advance of this meeting, and the information for the board book, and so COVID-19 is so dynamic that the data doesn't quite completely reflect where we are today. It reflects where we were a week ago, and a week ago we were still seeing quite a significant hospital volume. We still are, actually. We finally have come down to and I'll show you this in a minute, come down to what we thought was an incredibly high number that we had at our peak in July. We finally come down to that as of today, but it's taken a while. As you can see, this is what what COVID-19's been doing in the community. So really a tremendous spike that began in late November and into December following Thanksgiving and Christmas, and it lasted into January. Very, very intense time for the disease in North Texas. Next slide, please. And that's been followed by a pretty tremendous rise in the number of deaths from COVID as well. One thing that's very interesting about this curve is if you look at the legend at the bottom, you'll see that the orange part of the bars are deaths among people who did not have any known underlying health conditions. And you can see that unlike previous spikes, this spike has been accompanied by a pretty substantial number of deaths in people who did not have significant underlying conditions. And that's a little bit of a change. And so we're keeping our eye on that. That's, now that the numbers have gone down, that seems to have also gone away. But these big spikes do show that even people who are pretty healthy can be at risk for very bad outcomes from COVID. Not at the same rate, of course, but it's still there's still a significant risk. Next slide, please. Our volumes at JPS have really tracked along with those test results in the community, with a little bit of a lag because some people will know that they have COVID before they get sick enough to come into the hospital. But as you can see, we peaked, and this is inpatient only. If you add in the ED and patients on observation, we actually hit a maximum of over 205 patients in the hospital. But we're now tracking down, and as I mentioned, we're down to 128 in the hospital at this point in time. So that number has very mercifully fallen and allowed us to begin to resume some normal activities around here, which is great for our patients. Next slide, please. Our ICU volumes have actually stubbornly remained high through this period, and we still have a pretty significant ICU volume. This, of course, also lags the hospital volumes to some degree because the patients who get sick enough to go to the ICU frequently stay there for very long periods of time. Next slide, please. So what have we done in the last month? When we had the big surge, we really had to open up a whole slew of new care spaces for our patients. We opened some additional care spaces for COVID-19 patients and emergency services. So this is in our observation unit as well as in our admission holding unit. We actually stopped elective surgery completely and converted preoperative holding to a non-COVID-19 patient inpatient unit to allow us to utilize some of the other inpatient units more intensively for COVID-19. We actually consolidated our operating rooms so that we could make some additional staff available for this unit, and it was really amazing. Actually, many of our OR nurses had substantial experience in critical care and med-surg nursing, and so actually perioperative services was able to staff that unit almost completely when we opened it. And huge thanks to Deb Saunders, our Executive Director of Emergency Services, and her team for making that possible. We deployed all available employees that we could into direct patient care. So managers were in staffing, like nursing managers. Our clinical resource nurses were in staffing. So really finding all sorts of staff that we could get, and then have had to go out for lots of agency staff, some provided by the government, some some that we just had to acquire to make sure that we had all the staffing that we needed for this very large number of patients. We were able to stand up a serial testing program in inpatient psychiatry, which has allowed us to continue to manage behavioral health patients with minimal disruption. And this was actually a major step forward because prior to this, having this in place, when we'd find a positive patient in a unit, we would have to close it until we could prove that all the patients in the unit were negative. And so for a long period of time, so that was a pretty big disruptor for our behavioral health patients in our county. So that was really a huge win for our psychiatric service. And then we've had to stand up new testing regimes for our general inpatients and patients in labor and delivery. Mr. Early, do you want to speak about where we stand with the vaccine program?
Yeah, Rob, I do. Let me tell you what we've been doing, and I'm really proud of the team. And Doug Chung and Joy Parker have done an incredible amount of work. And what they're doing is trying to make sure that we have enough doses to provide people. The state has significantly cut us back on vaccine, and that's not a fault of the state. The state is giving it to major hub centers now. When you read about places like the Motor Speedway giving out a good deal of vaccine, you hear about Denton County giving out a lot of vaccine. We're part of that from a support standpoint. We want to get as much vaccine as arms as we can. Our focus here at JPS has been, one, our employees, first and foremost. Secondly, our patients. And Dr. Alawi and a good deal of our wonderful team in community health are calling those highest risk at patients and trying to get them in to get their shots. We've provided a huge amount of shots, and I'm proud. We were doing about 1,000 vaccines a day. We have cut that back so that we make sure that we have enough for our second vaccines. But Dr. Weber and members of the committee, I'm happy to inform you that we've given over our 25,000 vaccines, 25,126 vaccines. 19,995 of those are first vaccines, 5,131 are second vaccines. So the team's been doing an incredible job. When the state provides us vaccine, we provide more vaccines. But again, they are shifting a little bit of that to those mega centers. I know that the county is working really hard at trying to open up more mega centers so that more vaccines can be provided and given. But I'm really proud of the model that we've created at JPS. One, our employees first and foremost. Secondly, our patients at risk. And then we start looking at our homeless population and what we're providing for the care at our True Worth Clinic and also the inmate population and trying to provide it to our county jail. So we've been very consistent. For the last couple of days, we've only been giving second dose because that's all we've had. As we get more doses from the state, if we're able to open back up first doses, we will do that. But I think we're being very, very smart about it, and I'm really pleased with the number of people who've gotten their vaccines thus far. So Rob, thanks. I'm happy on vaccines to answer any questions that anybody has. The other thing, Rob, as you were saying, as we shift OR staff and others, we do the same. For those of you who have seen our OPC or seen our clinics, we're taking nurses off of their duties and putting them into the OPC to give the shots or to monitor people in their monitor time. We basically, when we were giving 1,000 vaccines a day, pretty much is and was our maximum. If you look at the space and the space that is needed for monitoring, if you look at the personnel that it takes to do this, that's really the max that JPS could do, would be 1,000 vaccines a day. And again, we've reduced that to focus now on second vaccines. But Dr. Weber, that's pretty much where we are with vaccines.
Robert,
No,
this is Dorothy.
Yes, ma'am.
Are we working with UNT Health Science Center since they are getting a larger, the county is working with them? Are we connected to that at all?
We're connected through Vinny and Public Health from a standpoint of them letting us know what they're doing. But we're not part of that because we're not a major distribution center. And so we get an idea of what's going on, but the reason we're not a major distribution center, and most of the hospitals aren't, THR I know is part of the hub because they've been able to have out space and do it outside of the hospital setting. We at JPS just don't have that space. So it's more a knowledge, Dorothy, than the fact that we're part of their plan.
Okay. All right. Thanks.
Yes, ma'am.
Robert.
Yes, sir.
Just want to say that Commissioner Brooks attended one of our ministers' meetings and directed and appointed me to the county task force, I guess that's what it was called, to work on a immunization plan to get the vaccine out in the community. And, you know, as all of us know, the least to get the vaccine is the minority community. And I was charged with trying to help get that segment of the community to at least get the vaccine. And so I just want to say to you and Dr. Duncan that Joy Parker has been outstanding. She worked with us. Matter of fact, I kind of got Dorothy mad because I said we used a specific clinic, but Joy was outstanding. We were able to get 7 pastors to get the vaccine, and we've done videos from your office, from the PIO office at the hospital. They've done videos, still shots, and interviews that we now are putting out throughout the community, and we're beginning to see a response in our churches, folk more agreeable. 2 weeks ago on a Wednesday night, I did a Zoom forum. We had 5 churches participate. Dr. Duncan was our speaker on the importance of getting the vaccine and the pluses of getting the vaccine, which also had a major impact. And I was at the meeting this morning, and that was the major topic of our meeting, is how well it has gone since we've gotten it and how well they were received at the clinic to get the shot, to get the vaccine. And so you heard nothing but positive responses from the pastors, and more individuals now have gotten the vaccine based on that.
Well, Pastor, right back at you for what you're doing, and thanks, because when that message comes from a specific community to a specific community, it's better heard. And so your words have a great deal of credibility. The other thing, Pastor, if I could make an editorial comment, I'm pretty convinced you've got a condo in heaven whenever that day happens. And now that condo just got bigger because you're on one more committee for the county. So every time you do that, I think your condo gets bigger. I thank you for that effort. And Dinah Brodeur and the communications team, Joy Parker and Doug Chung, I think have done an incredible amount of work. I would take JPS's model for giving out vaccines to the community, giving it to the most high-risk communities, those communities that had probably the greatest resistance to it. We didn't stop, and I'm really proud of the team. And Pastor, I'm really thankful for your words, because I know what you and Dorothy and Amanda and others are doing in communities that might be reluctant, and I'm grateful. So thank you, Pastor. I appreciate it.
Thank you. I just have to get back in Dorothy's good graces. That's all.
Ralph, thanks again, man.
I'm not going to intervene in that part at all.
Well, Ralph, I will tell you that Joy came to my rescue because your message got out to all the pastors in Como. So Joy has worked very well with us and to get JPS patients in Como their vaccine. So it worked. So thank you. Okay. And thanks to Joy too.
Dorothy, thank you. No, Joy has done, like I said, Joy and Doug have done incredible work. I'm very, very proud of them. They've worked tirelessly. They don't have weekends like the rest of us have. They're constantly working. So, Pastor, you might want to write Joy a note, because she got you in Dorothy's good graces again. It was Joy.
Yeah, I'll see you in a few minutes at another Zoom meeting. So
you got it. Thanks.
I hope you don't mind if a lot of us don't attend that condominium for quite a while.
Yeah, I understand. None of us are ready.
Right.
So, Chairman Weber, that's what I have on an update. Rob, thank you for allowing me to give that, but that's really where we stand with our vaccines.
Okay, any questions for Rob or the Reverend or anybody? I'd say job well done, man. Okay, the next one I have is 4C, which is service line presentation. Sound Physician Group, Dr. Assad.
And Dr. Weber, if you don't mind, before Dr. Assad starts, let me make a few comments. You know, it was a challenge when we switched hospitalist groups a couple of years ago, and we've had a lot of good questions from board members, quality committee members about how are the hospitalists doing. And one of the things that I think we have tried really hard to do is improve communications and try to make sure that our hospitalist group is doing the best that it can for our patients. And I know that when the Sound Physician Group first came, I think JPS was a little bit bigger in its needs than what they had expected. And I think that road at which they started on was bumpier than any of us expected it to be. I know that at first they brought in a lot of locums, which was a challenge. I knew that when you have that many locums, you have a disconnect from your community, you have a disconnect from the hallways. And after a little bit of a struggle, they brought in Dr. Saba Assad. And Dr. Assad has been, in my opinion, incredibly dedicated to JPS. There's a lot of heavy lifting in hospitalist care, and it's not particularly easy, and it doesn't go as smooth as we want it to. But I think that with Dr. Assad, that program has changed quite a bit. And Dr. Assad's going to join us. Dr. Assad also has, Julian is with her, and Julian is special to us because Julian started out here as an administrative intern. And he did a couple things in that time period. He grew a lot. He learned about JPS. He became a part of quite the analytics for Sound. He also got really good in that he and his wife had a baby. And when you have a baby, you really learn about life. So I think he is understanding a good deal about everything that there is. So Dr. Weber, I wanted to introduce to you Dr. Assad, and I know Dorothy, you and others had some really good questions when we made this change, and some poignant questions about where are you going, what are you doing, why are you doing it? So I know that there is a PowerPoint presentation that makes me a little bit scared because it's measured in inches, not in words, and that scared me. But Karen Duncan and Dr. Assad and others have spent a lot of time on this, and I wanted Dr. Assad to have that introduction. So Dr. Weber, thank you for affording me that.
No, you bet. Dr. Assad, are you there?
Yes, Dr. Weber, I'm very much here. Thank you for having myself and Julian, my site program manager,
Julian,
here.
You guys have a tough job to do, let me tell you. I'll be happy to sit through an inch presentation at any time.
No, thank you for having us here. We consider it both an honor and a privilege. And over here, our goal today is to give a very high-level overview of Sound partnership at JPS in delivering quality care. Next. Before I go into any details about what JPS Sound relationship is at JPS, I would just give, again, a very high-level overview of Sound as an organization. Sound is a national company which has over 300 hospitals. In the hospitals where Sound is present, it has hospital medicine service line, critical care, ICU, ER, physician advisory, and as of most recent, they have ventured into anesthesiology and cancer care. Strictly talking about JPS, we do have the hospital medicine, physician advisory, and are going to be entering soon in a partnership with the anesthesiology service of Sound at JPS in June. As far as hospital medicine is concerned, our program started on February 5th, 2014. As a matter of fact, tomorrow, it's still hard to believe. It's going to be our 8th year anniversary, and really looking forward to it. During all these years,
hello. It's 4 o'clock. Looks like we have about 5 people on the line.
Who's that?
I have no idea where that came from.
Yeah, Mendenhall just left.
So I think we should keep going on with this meeting. I don't know where that mysterious voice came from, but we'll keep going. So Dr. Assad, if you'll continue, that'd be great.
Oh yeah, please do.
For some odd reason, I think our screen has got stuck, but can you still hear me?
Yes.
Okay, so we have seen year-over-year growth in volume. It is about 11% every year, and the highest jump was in 2015, where we increased to about 20%. We made sure that as the volume was expanding, we are also advocating for appropriately team expansion. We really have to thank the executive suite and the board to allow us to have that expansion. So when we started, we were at 27 clinical FTEs. We currently stand at 36.5. During this time, we had made sure that we leveraged the Sound proprietary technology platform, which includes the Sound Metrics, which is a data analytic platform, Sound Institute, which provides our providers with all the modules they need to keep up to date, and Knowledge Center. And the beauty about Knowledge Center is that out of greater than 300 hospitals, if there is any good idea taking place somewhere, we are able to do some sharing of that. I will just now let Julian talk about leadership and our clinical performance nurse.
I just want to say thank you to Dr. Assad and thank you, Mr. Early, as well, for that introduction. Yeah, from a leadership perspective here at Sound, we operate under a dyad and bifurcated model, really. What that means is we have a clinical chief hospitalist who oversees the clinical perspective of the entire program. We also have a program manager who oversees the operational, but collectively they both oversee the entire program. In order to also support this large site that we have with 36.5 FTEs, we have 2 associate chiefs. We also have 2 team leads. All of our providers are actively engaged in at least one committee across the hospital. That's very intentional. Sound makes deep investments in developing our physician leaders and our operational leaders. Just to give you one example of that, Dr. Assad's been here for 7 to 8 years at JPS, and during that time she's expanded her role. She also serves as the senior physician executive in Acclaim, who oversees the hospital medicine service line, which includes the teaching team. Most recently, her role expanded to become the executive director of population health. Although this is just one example, our entire team is highly engaged and motivated and integrated into the hospital. Another key component to our team are the clinical performance nurses. We usually refer to them as CPNs. And they're one of the drivers to our physician performance. They work alongside Dr. Assad on a daily basis to identify barriers associated with patient throughput. And then they collaborate with JPS case management and ancillary services to ensure that we remove those barriers in a timely manner. So all these components that we just mentioned make up our team. They're really what drive and help us provide quality care across the hospital, Tarrant County, and provide it in a cost-effective manner. Dr. Assad will now elaborate on some of the efforts that our team have been involved in the last few years. If you can please proceed to the next slide. Next slide, please.
Thank you, Julian. So out of all the slides in this deck, I consider this as the heart of the slide deck because it explains the why for my team. For whatever we do, our center is and our why is our patient. It goes without saying how impactful and unprecedented this COVID pandemic has been. Like the rest of the world, we were also learning about this pandemic. It's just to give an idea, we just saw in the previous presentations how it has impacted even the healthcare workers in the hospital. My team was looking after 80% of the COVID patients in the hospital, and we didn't do it alone. We did it in collaboration with our nursing colleagues, case management, rest of the providers. But it started off, there was a fear, the concerns on the provider's part was real. I mean, we were worried about our own family, but what we did was we just tried to put our fear and worries aside and rose to a higher purpose, and that was to provide high quality care to our patients. Since we were looking after close to 80% of the COVID patients in JPS, our expertise was heavily relied upon, and we were an integral part of whether it was COVID Command Center led by Dr. Duncan, or it was the clinical steering team led by Dr. Stephenson and Dr. Davis. And all of this great collaboration between nursing, providers, case management led to great operational successes. I'm sure a lot of you have heard about that across the Metroplex, staffing has been a huge challenge, not just unique to providers, nurses, respiratory therapists, and that was not different for us as well because we had never seen those volumes. So once we had the first wave in July, myself and Julian were very intentional, focused. We realized that come winter, we're going to be faced with the most unprecedented challenge in the staffing. Hence, we made sure that we are appropriately staffed and prepared. And I'm glad to say, I think the thing we feared, we were able to combat that with our proactiveness. I'd like to touch on lightly throughput. Given that JPS is a level 1 trauma hospital, county hospital, throughput is always a challenge. Last year, Dr. Duncan asked us to take over the throughput committee. We didn't do it alone. We co-chaired it with our nursing lead, Wanda and Dina Dent. I really have to learned a lot from them. What we did was weekly have these meetings with every stakeholder. These meetings have all the clinical leaders, nurses, case management, ancillary services, and we go person by person asking them what are their biggest impending issues in as near future as 1 week. But we just don't even look at the near-term risks. We also, with help of Julian, who is a master of developing data analytics platform, we developed close to 60 measures with close collaboration with our IT team, and that allows us to look at from the time the patient enters into the hospital to the time patient leaves, where are our bottlenecks. I would also like to add that the key success to its throughput in a hospital is single source of truth. In 2018, so let me take a step back. In 2014, we established in-person multidisciplinary rounding, but very early on realized that it may not be something which every service line can use. Plus, what do you do with all the communications that happen throughout the day? How do you get a platform where everyone can communicate real time in addition to the in-person multidisciplinary rounding? So in 2018, we came up with, along with collaboration with case management, with a novel concept of using Epic, which is our EMR, and develop a virtual multidisciplinary rounding tool. Fast forward 3 years, every service line in JPS has been trained. All clinicians use it, nursing, case management, and we use that as a single source of truth, whether it is our bed control, whether it is our multiple meetings with the ancillary services throughout the day. Lastly, I would like to just comment briefly on cardiac monitoring. Cardiac monitoring is such a coveted commodity in any hospital. You talk to any hospital, they always want to have more cardiac monitoring beds. Wanda in 2016 approached us that how could we tackle this problem? So we used American Heart Association guidelines, again, got nursing, case management, all other service lines, with heavy input from surgery, because American Heart Association may not take into account a lot of surgical and trauma patient needs, and came up with a guideline and built that guideline in Epic, trained all providers, and the purpose of all of this was optimize our cardiac monitoring utilization. Next slide. I know we don't have as much time to capture what has been done in 8 years. This is just a list of some of the projects we have led or championed. I will just pick one of the projects out of this and briefly go over, and this is one of the more recent projects. It is called 6-Click. As the name says, there are actually 6 questions for physical therapy, 6 questions for occupational therapy. In 2019, I was sent to the Thomas Jefferson University for Population Health. And over there, I realized that Cleveland Clinic and Boston Hospital were using a tool which was called 6-Click. And what it does is, name it fancy, but it's very cheap software, about cost $180, but what it delivers is invaluable. makes sure that whenever a PT and OT recommends the next site of care, it is matched with an objective evidence of does that subjective feeling of what's the next site of care, like a rehab or SNF, does that actually match the standard guidelines as well? Currently, that tool has already been built. All service lines, including physical therapy, occupational therapy, has been trained how to use it. Case management, nursing, everyone is using it. We are in the process of, we have gathered all the data, and now we are in the analytics phase. More to come on that. Any questions? All right, we'll move on to the next slide. And I will now let Julian talk about the first part of the scorecard 2020.
Hey, Dr. Assad, and I just want to echo what Dr. Assad mentioned about the patients being at the center of everything that we do. If you get an opportunity to interact with one of our team members, it's very palpable that the patients are at the center of everything we do. It's really our why. So thank you for sharing that, Dr. Assad. For today's purpose, we did want to highlight our most recent performance, which is the 2020 scorecard. More specifically, Q1 through Q3, there's a lag, about a 45-day to 60-day lag on some of the measures, and as a result, Q4 is unavailable today. So, in addition, we've also split up the scorecard into two different slides. There's a lot of information on our scorecard, so we wanted to make it easier on the eye. I did want to focus on two particular measures on this scorecard. Beginning with discharge orders before noon. Discharge orders before noon has actually been a measure that's been a part of our scorecard since the inception of our program. It's a measure that's nationally accepted within the hospital medicine service line across the nation. Hospitals typically like to be around the 50% discharge orders before noon, and as you can see, we're over the 50% consistently. I will note discharging patients is a very complex process. It really requires a multidisciplinary approach. So as Dr. Assad was mentioning earlier, this virtual MDR, which we augmented in 2018, has really become the single source of truth to optimize discharges. Now across the hospital where case management is using this tool as a single source of truth, our nursing department is using the virtual MDR, and also physicians across different service lines within the hospital. Now, the second measure I would like to focus on is the readmission rate, which is the all-cause readmission rate. This excludes all deaths, all patients who left against medical advice, and all planned readmissions, such as oncology visits or OB visits in the hospital. I do want to point out that the variance that you see between Q1 and Q2 is because we actually transitioned from an old MIDAS reporting tool to a EPIC reporting tool to better align with the hospital's methodology. The difference between the two methodologies is that the EPIC reporting tool actually pulls a rolling 12 months. So the reason why it looks a little higher than Q1 is because it incorporates the peaks that you see throughout the year, which we see in winter and in summer. So, but as you can tell, over Q2 and Q3, we have made improvements, and it really helps us focus and hone in on our action plan. The interesting thing about readmission rate measure in the world of hospital medicine is that it really pushes our team to not only collaborate within the confines of the hospital walls, but it also allows us to collaborate across the district, not just within the hospital, but with our outpatient colleagues. Some of the initiatives that we've implemented here at JPS in collaboration with the outpatient colleagues. Dr. Assad already mentioned one, which was a 6-click mobility assessment, and that's really an objective tool that allows us to discharge patients to the appropriate next site of care. Another initiative is in collaboration, we've relaunched a 1-click follow-up appointment to ensure our patients are receiving a follow-up appointment in a timely manner within 30 days, and with the appropriate provider, whether it's specialty clinic or primary care clinic. We've also collaborated with ED in an effort to reduce readmissions. So it allows us to prevent readmissions in real time as our patients enter our ED. And then lastly, and most recently, our outpatient chronic disease program, which Dr. Assad and the team were heavily involved with Dr. Alawi, community health, on developing and focusing on the top 4 chronic diseases and ensuring that those patients had the resources when we were discharging them. Before moving on to our next slide, does anybody have any questions?
Yes, I have a question. This is DT on the readmission rate. Is it possible for you to go back and recalculate Q1? Because the date has been in Epic since 2000, for the last 5 or 7 years already, right?
So is your question if we can go back to recalculate Q1 using the new Epic reporting tool that we mentioned?
Yeah, because, is there a reason why you only pick Q2 and 3 on Epic and the other one on Midas when the data's already in there just to pull it?
No, it's not a particular. I appreciate the question, DT. The reason why we showed Q1 reflecting the Midas reporting tool is because we were measured using that reporting tool. However, having said that, we'd be more than happy to work with the data analytics team to see what that performance would look like using the rolling 12 months.
And I will just add one more thing. So these scorecards are developed in collaboration with Acclaim and JPS. In Q1, we were still using the Midas technology. When the hospital chose to move to a different technology, it wasn't by our choice. We were given the option that, well, hospital is going in that direction, what do you want? We wanted to align with the hospital, and that's why we said if the hospital is going to that methodology, which is directly from Epic and is more accurate, we will take that and move along with it.
Right. But the data should already be there, right, for you guys to pull? Or do they have to run it separately?
Absolutely. We can absolutely ask our data analytic team on Acclaim who can give us that, and we can absolutely get it to you.
Because I was surprised that when you guys make a comment that during the winter time, we have more readmission, but we should have looked back just 1 quarter to make sure that it's consistent all the way through. But is there any way you can educate us? Because it's because sometimes we use the same terminology by different departments. Is there a difference between this transition of care and the transition of care that we just heard previously by Laura?
I'm sorry, can you repeat the question, DT?
The transition of care that you have here, is that the same as the transition of care that Laura just presented to us about maybe 15 minutes ago?
Mr. Wynn, no, this is, it's just basically under transition of care, it could be the patient experience or it could be metrics such as the discharge order before noon. So this is a totally different measure. This is just a provider putting an order in Epic to say that I am discharging the patient.
Okay. So do you look back and look at the discharge, the lay score here, and match it up with the readmission rate and see if it's as predicted, high or lower as predicted, or do you guys look at that at all?
Mr. Wynn, can you repeat it one more time?
When you have a discharge order and for transition care and all that stuff, and then you have the readmission rate, during discharge, usually you have a lay score sitting there to predict to see if how likely that patient will come back or die or whatever that is. Is there a way you guys can link those back and see, is it as we expected, higher, lower, so that we can start, getting better and better at looking to see what the outcome should be?
So, Mr. Wynn, you bring up a great question. So I think what you're asking is, and please correct me if my understanding is incorrect about it, you're saying that have we ever done a look back where we've looked at how we were doing with the discharge, say before noon, and then how does that actually relate to our readmission, correct?
Yes, because it's, if you take the death and the expected admission back to the hospital, because some of those are, expected, and there's a lay score that assigned to the patient when doing after discharge.
Yes. So what we do is, you're absolutely right. So what we do is we actually have trained all our providers to add lay score in the patient list. Patient list is our rounding list. And lay score varies. It is a high, low, and medium risk. What we do is we actually train providers. If you see for any patient a score of 40 to 45, which is somewhere in the middle, and the reason we select middle is because these are the cases we definitely don't want to miss. So anything which is 40 and above, we make sure that our clinical performance nurses who sit in the sound office, they run the list with the provider every single day. So if they are discharging a patient whose base score is 40 and above, they are trained to make sure that they are discharged with all the appropriate resources. Now, when the readmission happens, our clinical nurses do a drill down of each individual case, and they are escalated to me as to what could we have done differently. Did we make sure that there was a follow-up? We do a full drill down. Was a follow-up appointment made or not? Was the clinical care, was it that the patient was discharged too prematurely? That is why the patient came back. Did the patient actually complete their appointment or not? Did we send them with resources such as behavioral health, social work? Did they had lack of medication? Did we send them with a voucher? Did they not collect their medication? So there is a real deep dive done, which is done every quarter, so then we can action plan around.
Mm-hmm. Because I like your the way that you just described it, because that's kind of what I was alluding to, is that how do we get ourselves to the point where we can look at the average length of stay, and based on discharge, and are we discharging, is it better for us to keep the patient a little bit longer so that they can acclimate to go home rather than go into other post-acute care and risk of potential coming back for readmission and all that stuff?
Great question, Ms. Bowen. So I think that is why it is extremely important to look at, is the patient clinically ready or not? So historically, I'll say quarter over quarter, when I have done analysis, and I ran the readmission task force as well at some point, and every time I have seen why a patient actually comes back, we do this persistently every quarter. We look at every individual case why they came back. I have not yet been able to find that it came back because the patient was discharged too prematurely. Yes, is it true that sometimes patients are very sick? And I know if Dr. Kamath is on the call, he'll echo my feelings. We know that the patient is sick, but at some point it's about the risk benefit of, if I make the patient stay longer in the hospital, the patient could actually contract other illnesses. It's a very fine risk at what is the right time. So we use our guider as what is called as GMLOS. So GMLOS is a CMS predictive tool which says for this particular diagnosis, the patient should stay for so many days. And I will say that in JPS, our actually length of stay is longer than GMLOS, not because of certain other reasons, because of placement, etc. So I would like to say that it's very difficult to actually meet the GMLOS that CMS predicts, and so our patients are definitely clinically ready at this point.
Sounds great. Thank you.
Good question, DT.
Thank you, Mr. Wen. Next slide, please. Before moving on to the second part of our scorecard, we did want to briefly highlight the progress our team has made over the years since 2014. And this is specific to the provider communication domain in our HCAP scores. The 3 questions that are included on the provider communication domain are listed here on the screen. And really, this success is not only attributed to the work our team has done year over year. We've been able to not only increase, but also sustain that growth. But we really would like to give kudos to Laura Burnside and the work her team has done alongside our team in collaboration. Some of the support that her team has provided is shadowing and real-time feedback to our providers. We're currently in the process of every month we collaborate on our post-discharge call initiative, where we look at trends associated with post-discharge calls, and then we formulate action plans. And this is a way to help us address trends associated with HCAPs in real time before the HCAPs are finalized. So really, a huge kudos to not only our team, but also collaboration with Laura Burnside and her team. So thank you. Next slide, please. Now, Dr. Assad will elaborate a little bit more on the second portion of our scorecard.
Yeah, Julian is going to leave the toughest for me over here. All right, so this is our second part of the 2020 scorecard, which is the patient experience measure. So the patient experience measure has two pieces to it. One is the performance and the other is a process measure. As far as the performance measure is concerned, it has the 3 provider question, which is the listen, respect, and explain. And then, as Mr. Wynn was asking previously, it has that transitions of care question in it as well. The first glance at this slide actually suggests that we are doing not as well as we would have liked. But the truth is that this just is reflected of the higher standards we have kept for ourselves. As would be true for any metric, year over year, the bar has been increased. We are not very different from the baseline over here. I will also like to point out one thing that has really impacted the patient experience for our patients. It has been COVID. I think all providers know that in order to deliver the great experience to our patients, there has to be a connection with the patient that has to be developed. But the COVID has made that connection so difficult. The cumbersome PPE, it is very difficult to communicate with patients. They can't see your facial expression, empathy, which is so important in patient experience, that really cannot be conveyed. You can't sit next to the patient, hand holding, gentle hand on the shoulder. It's just not possible. Then the unknown about the disease, that definitely affects the patient, and the visitation policy. So all of that is really definitely has made this very difficult. I actually had a detailed discussion with Laura, and she told me that we are not unique in this impact which we are seeing on the patient experience. Actually, nationally, this is being seen to the point that CMS for the last 8 to 9 months has not been publicly reporting it. Having said that, like any other thing, I would like to say we want to take this as a challenge, and we have taken it as a challenge. What we are trying to do differently is, I am so happy that Leanne Franklin got the praise because she really deserves it. We've had several team meetings conducted, which were led by her chaplain. So chaplain basically communicates with us. We do a press meeting. We discuss everything that we are going to discuss in the meeting. Then we get the patient. If not the patient, like if the patient doesn't have capacity, then the family members, appropriate family representatives will be there, nurse will be there, case management, social worker will be there. And it is such a wholesome experience and allows us to kind of build that bridge which COVID has created. And so that is just one example, and I think more to come as we become more innovative with the changing landscape. Any questions? Can you move on to the next slide?
Just in conclusion, since we were reviewing our most recent performance, we did want to give an update of our 2021 scorecard. All of our measures found on 2021 scorecard are the same from the previous scorecard. However, we have included one additional measure, which is the one in the rectangular bold, which is the follow-up appointment scheduled within 30 days after discharge. And like I mentioned earlier, this really helps in our initiative with readmissions and collaborating with our outpatient colleagues and nursing to ensure that our patients are receiving the appropriate follow-up appointments post-discharge. With that being said, we will pause here and open it up for any questions or discussion. Thank you.
Comments, questions? A lot of work. Well done.
Chuck, on the follow up on the appointments, 30 days, is that to come back to them or just anywhere in the system?
I'm sorry, can you repeat the latter part of that question?
On your follow-up schedule appointment, is that to return to see a primary care doctor in the system or to a sound physician? That's my question.
Great question, Dorothy. So we like this measure because this has been developed in collaboration with Joy Parker, Dr. Alawi, our nursing colleagues. And the purpose of this measure is that we want to make sure that patient comes back to see, not comes back, meaning has an appropriate appointment with a primary care doctor or a specialist. Because sometimes the specialist could be acting like a primary doctor, for example, Dr. Karmat, if there is a CHF patient, and this is a very decompensated CHF patient, we want to make sure that the patient, he or she sees Dr. Karmat and probably not the PCP. Definitely there should be a PCP appointment. And I would also just highlight, while it says 30-day, I think that is why this measure is so important, because the responsibility of the provider is identify the right person, whether it is specialist or PCP, and identify the right time. Because for some patients, 30 days we may need something as less as 3 or 7 days.
Okay, thank you. That was the answer. That was my question. Thank you. Mm-hmm.
Thank you, Mrs. DeVoe.
Thank you.
Anything else for Julian or?
I'm just curious. This is DT. I'm just curious how what is the percentage of the patient that discharged from a hospital that actually been assigned to a PCP, and how often do they show up again without PCP?
Great question, Mr. Wynn. So I will let part of it be answered by Dr. Alawi, but part I'll answer. So every single patient we see over here, we make sure that the patient has an appointment. So our social worker, case management nurses combine together to make sure that the patient has an appointment. Dr. Alawi and Joy Parker has received several calls from me where I basically say, hey, I need an appointment. I'm unable to get an appointment. We don't want to discharge this patient. And I will say kudos to Dr. Alawi and Joy Parker. It could be any time of the day. And they will say, all right, appointment made, this is the time. So we try our very best, and we don't let the patient go without an appointment. Now, the showing up piece, I'm going to let Dr. Alawi answer that.
Yeah, and hey, DT, and Dr. Alawi might comment. And yes, Dr. Assad, I think we've created some really great partnerships from inpatient to outpatient, which is definitely our goal. Our no-show rate has been around that 18 to 20% just overall for patient appointments. We do see we do connect patients that don't have a PCP to our Health Connect clinic. And we do see a higher no-show rate in that population. This is our effort to establish care, which is the right thing to do. And certainly, I can't say enough of the great work that Camille Sherratt and her team has done in really ensuring that these appointments get made and making sure that we have the technology to optimize that workflow. But certainly that first step is getting them back to their PCP for that follow-up. And so that's the no-show rate that we average. And certainly I can allow Dr. Alawi to comment on that as well.
What I would like to add is that with the coming on of telehealth, we've actually seen a substantial drop in our no-show rate. We do typically no-show about 18 to 20% on our face-to-face visits, but we actually no-show a lot less on our telehealth visits, closer to a 9 to 11% rate. And so what we've actually done to help facilitate is that one-click scheduling that Dr. Assad was talking about, which is us one-clicking a patient in to either Health Connect or to their PCP for follow-up. We've actually converted that over to telehealth. A, because we'll make sure that they get the appointment they need and the accessibility that they need. And B, if their provider feels like they need to see them in person, we can always make sure we get them scheduled in person. We also now have the ability to get them transportation to the clinic if they need. And, Dr. Assad briefly grazed over our outpatient chronic disease management program, but it's actually very similar to the outpatient COVID program in terms of having a case manager calling these patients every day for the first week after they leave the hospital, then every other day, and then at least once a week for the next 90 days. And so they're also helping to facilitate getting these patients in for their appointments. And that's a program we started about 4 or 5 months ago. And so all of those things are actually helping us have a much better show rate at getting these patients in. Did that help?
Yes, thank you.
All righty. Anybody else got any questions for Dr. Assad, Dr. Alawi, or Julia?
I would just like to have some closing remarks that we really value this partnership and don't take it lightly for 1 second. We really consider it a privilege to be here. And we want to make sure that along the way, we match the initiatives and goals of JPS with everything we do and continue to provide as a goal quality care to our Tarrant County patients.
Gotcha.
Yeah.
Rob, you want to comment?
I just wanted to say, you know, the contributions of sound, as you can see, are pretty phenomenal. Dr. Assad's an incredible leader, and I'm just grateful to her every day for the partnership and everything they're trying to do to deliver the highest quality care possible for our patients. So.
Yeah, and the scorecard looks very detailed and very good.
So. And the only other thing I'll say is that this is going to be the first of many presentations. So this will be a regular feature each month where we'll have different of our provider service lines coming before you to discuss their results and the ways in which they're trying to make things better for our patients at JPS. So the current plan is that surgery is coming next month. So.
And Dr. Stevenson, I'd just like to add that whenever the board wants us to come back, we'll be more than happy.
Chairman Weber, I just want to let you know that Dr. Stevenson volunteered the Department of Surgery and volunteered me to present next month. So thank you very much, Dr. Stevenson.
It's my pleasure, my friend.
Rick, it was my idea, so sorry.
Thank you, Dr. Alawi. Appreciate it.
All right. Dr. Weber, are you ready to move on now?
I may have to start drinking since you're going to bring surgery on. Jeez.
Yeah. So this month is Heart Month, and so I thought it would be incredibly timely as part of our innovation corner to bring forward three of our groups who provide phenomenal health care to patients with heart disease at JPS for presentation. And so that you can see some of the key results that we're having in the care of patients with heart disease. The one thing I would like to just say to the board and to anyone listening at home is that tomorrow is Wear Red Day for heart disease, and so please remember to wear red so that to show that you stand with all those people out there who are suffering with heart disease, which remains the leading cause of death in the United States. So at least a non-COVID cause, because COVID has gotten ahead this year. But in any case, I believe the first presentation is our AMI group, and our presenters are Chrissy Feinauer, who is our program coordinator for our AMI program, as well as Dr. Lakhandwala, who is one of our physician champions for our acute myocardial infarction or heart attack program. So, so without further ado, I'll turn it over to them.
Thank you. Hello. Good afternoon, everybody. Thank you for allowing me to be here to present my program to you. My name is Chrissy Feinauer. I am the chest pain coordinator here at JPS. And
We're going to have to flip through a whole bunch of slides, I think. I think there's a lot of appendices here with the sound team. Can we just forward until we get to their... this is all for the board's information. Thank you for including it, Dr. Assad, but we're going to have to go all the way to our AMI program. Many, many, many pages. This is the inch that Dr. Assad included. There we go.
Very good.
Perfect.
Okay.
Thank you.
All right. So acute myocardial infarction, for those of you who don't know, that's our heart attack patients. And so anytime I reference AMI or MI, I'm talking about someone that's had a heart attack. So for our program, our leadership is as follows. So we go up to our Chief Nursing Officer, Ms. Dina Dent, the Director of Clinical Services, which is Elizabeth Rogers. Then you have myself. I am the program coordinator. My committee co-chair is Tabitha Lewis as well. She's actually on the call here as well. I have two specialized cardiologists, and they're interventional cardiologists, so they've had a lot of extra training, but they're the special guys that go in and get those clots out and save your life when you're having a heart attack. So my medical director for the program is Dr. Kumar. And then I actually have my physician champion, Dr. Juzar Lakanwala. He's on the call as well with me today. And I do have 2 physician champions for our emergency department, since most of these patients come in through the emergency department. So Dr. Stefan Meyering and Dr. Jessica Kirby, she's actually also the medical director of our emergency department. Next slide. So a little bit of our program overview. Our mission is to improve the care of the heart attack patients in our community. We do report to Joint Commission. We have 4 goals that we report to them. We have several others, but the ones that we report to Joint Commission. So we have door to initial EKG, which is going to be probably one of your most important ones. But we want to make sure we get that in less than 10 minutes. Door to balloon, which is the time the patient arrives in the emergency department to the time that we've removed that clot in their heart. We want that in less than 90 minutes. We have our 3rd goal, which is first medical contact to balloon. And so these are going to be our heart attack patients that come in by ambulance. And so the time that the EMS providers first lay hands on them to the time that we remove that clot in their heart, we want that in less than 90 minutes. And we have one final goal, which is going to be a cardiac rehab referral rate, which is to get them into outpatient cardiac rehab. And I mean, that's such a huge benefit for these heart attack patients, and helping them prevent a second heart attack and helping them return to the normally daily functions. Next slide. So some of our program highlights. We were just recently recertified as a disease-specific program with Joint Commission just this past November. It was a very successful survey. We do hold monthly collaborative multidisciplinary committee, and it includes everybody from the emergency department, administration. I have MedStar, which is our #1 EMS provider. They participate in my meetings, sound, everybody. It's a very collaborative committee. I have a very active physician engagement team and collaboration. And that was something that our surveyor also noted. That it's a very high participation with our physicians, and I really appreciate that. We do process review of every heart attack that comes in and every inpatient that develops into a heart attack. We also review all of the cancellations that we have. I provide real-time feedback to all of our committee members and any team member that was involved in the heart attack. We participate in the American College of Cardiology, the chest pain MI registry, and we do that to benchmark our data nationally, and we present that quarterly to our committee as well. Most recently, we also developed in an emergency department AMI subcommittee, and this was really helped us to decrease a lot of these ED to cath lab times and help that process flow a lot smoother. And we provide continuous education to nurses and the physicians as well. Next slide.
So I just have a quick question.
Yes.
When you say cancellation, what do you mean cancellation?
So we have our EMS providers, sometimes they will do an EKG out in the field, and they might interpret it as a heart attack. And so what happens, we go through a process of, we scan all of these questionable EKGs to our 2 providers, Dr. Lakanwala and Dr. Kumar, and they review it and they determine if this is actually truly a STEMI or a heart attack.
Okay.
Some of these end up getting canceled and some don't.
Okay.
But
thank you for the.
I want to review that process and make sure that we're following the process.
Yes. Thank you.
Thank you. So JPS, we were actually issued the 2020 Silver Performance Achievement Award by the American College of Cardiology. And this was in just this recently, but this was given to us for our excellence in AMI care, or our heart attack care. And very few hospitals received this award, so we were very proud of this. Because of this award, we were actually mentioned in the U.S. News Best Hospital 2021 edition as well. Next slide. And I think Dr. Locke is going to talk from here.
Right here. So
Thanks for that intro, Christy. And this slide is just to show the great work that y'all are doing. Any patient that comes in with a STEMI, this is patients with a heart attack where we think every minute matters. So this is the sort of the heart of cardiology where we want to save every bit of muscle. And the slide here, gets presented for every patient where we analyze. You see the 3 gray boxes. We're looking at the times the EMS is spending with these patients, the time the ER is spending, and then how fast we're able to get them to the cath lab and open up the artery. And so those are broken down into multiple shorter segments, and we've worked through multiple individual barriers of where we can cut down. We're trying to minimize, first of all, our door-to-room time, which is something we can control, but then there's also the first medical contact to PCI, which is how the EMS brings it in. And eventually, what we hope as cardiologists is to impact the chest pain to PCI time. So this is one of our cases where we've had a door-to-balloon time of 43 minutes. Again, one of the ways we can achieve such a short door-to-balloon time is a good EMS activation, so they pre-activate. We set the EKG, as you see in this case, was sent ahead of time, so our team could get en route and be ready for the patient even before they got here. Do you have anything to add, Christy, on the slide?
Good.
Can you move to the next slide?
Move on to the next. So this is our metrics and how we look at it through the months of 2020 through the pandemic. I think the first line there is the door-to-balloon time that we monitor with the 90 minutes. Again, then it's broken down, and also we have the first medical contact. The third line, which is the first medical contact to PCI, tends to be a little variable based on how many times the EMS is able to activate it pre-hospital versus not. And sometimes if they're coming with atypical symptoms, the EKG may be done later. But we do pretty good on once we get the EKG and we know it's a STEMI, take them up to the lab and open up the artery. And then there's also the medical therapy involved that we monitor whether they get started on all the appropriate medications for AMI. Next slide. So we just put this data, and thanks to Christy and Tabitha for kind of putting this data out of curiosity as to how this program is done through the pandemic. I think that from the perspective, this is just the green line represents our goals nationwide, with the door-to-balloon time being 90 minutes and a door-to-EKG time being 10 minutes, and it looks like we have stayed well below that. Nationally, if you look at the big registry data presented through the pandemic, the general theme is that that there's been a slight drop in the STEMI volume because of, again, patients' reluctance to come in. And also there has been an increase in door-to-balloon time, again, because of the complexities that COVID brings to the table. And also there's been an increase in in-hospital STEMI mortality because the patients are presenting later. If you look at the next slide, this is our...
Can you go to the next slide?
This is our STEMI volume for all of 2020. We did see a slight drop somewhere in April, May, but we've had a steady volume of STEMI cases eventually, and the red bars are the amount of patients with STEMI and were COVID positive. Of course, none of these are known ahead of time, so when they come in, we may have a suspicion that they could be COVID positive, but the tests are not back in the time for us to know. So we've had to preemptively change our flow of work so that we are universally taking certain precautions on all these patients coming in. Next slide. Okay. So this slide, it's interesting, and it just kind of shows what's happened nationally. We do see the first one is the heart attack responses per day, and the gray is the one from the year before, and the red is from 2020. Right around March, there is a little dip in the STEMI volume, and then it kind of stabilizes there. We have seen, if you look at the bottom graph, comparing the years from 2019 to 2020, there is an increase in cardiac arrest cases. There's an increase in, people people that couldn't make it even to the hospital. So there has been that sort of increase that we see because of like the delay in presentation or seeking care. And I think the last slide here is one more slide is our patient volumes. We've talked before.
On the previous slide,
For the future goals.
I just had one question, I'm sorry.
Yes, ma'am.
On the previous slide, where you're saying the higher incidence of cases, either of them coming in, is that something, has there been any study involving whether they did have primary care and presenting, or if they did not have primary care? Or is that something that's just not possible to determine at this?
So your question is whether these patients had primary care physicians?
Since these
Amanda, actually, I think I can answer this question a little bit better because this is really a COVID phenomenon.
Okay.
So what we're seeing here, if I can this is a graph that we've looked at quite a bit around this area. And what you're seeing here is we're seeing an increase in cardiac arrests at home where they're found in cardiac arrest when EMS gets there, an increase in dead on scene, okay? And an increase in so dead that they didn't even attempt resuscitation because they were long gone. You see what I'm saying?
Yeah.
And so this, we believe, and this has been seen around the country, this is not in any way, this is MedStar data, so this isn't JPS data, this is, and what is, been sorted out about this is that this is a reflection of people being afraid to go to the hospital because of COVID-19. They don't want to come in, and so they, even if they're having crushing substernal chest pain, and under normal circumstances, they would say, I got to go to the hospital. They're saying, no, I'll be okay. I'm afraid to go. And then the family finally calls when they're not responsive anymore. You see,
Okay.
the EMS goes out there and then they're not alive. And so this has been seen around the country with really all EMS services, and it's not by no means unique to JPS. And this is, of course, regional data. So.
Yes. Oh, fantastic. Thank you.
Yeah,
Well, not
what the
fantastic
slide
about that.
doesn't also show is that when they present late, even if they're alive, they're just sicker, and your in-hospital mortality is also much higher.
From the interesting. Thank you.
So quickly, I'm gonna let you go to the last slide of the future goals.
Okay. One more slide over. Thank you. All right, so some of our future goals for our program, obviously we want to decrease our time, our first medical contact to intervention or PCI, balloon. We want to decrease that time overall for our ambulance patients and our walk-in patients. So that's a huge goal. We want to work on also our inpatients that develop into heart attacks. And so we want to decrease that time from the time that we see that EKG that's showing that they're having a heart attack to the time they get intervention. We want to work on that process as well. Obviously, we want to increase our referrals to outpatient cardiac rehab because it is such a benefit for these patients. And eventually, we want to possibly advance our certification to become a primary heart attack center. And that is it. If there are any questions, I'll be happy to answer them.
Good work once again.
Thank you so much.
Chuck, before we
I have
leave
a
on
quick
that,
question on for education only. What is the significance of the 90 minutes? Can you, for some of us who are not in
it's a national standard, and so that's something that not just so JPS, we have kind of actually an internal goal of less than 75 minutes. And we actually even monitor it for less than 60 minutes as well. But it's a national standard for 90 minutes, and they're showing mortality, everything increases over that 90-minute mark. So that's kind of our little benchmark set right there.
Oh, I see. Thank you.
Thank you.
Time is muscle for the heart, and like usually if you wait 6 hours, you've lost most of the muscle. They say within 90 minutes, you still have time to save most of it. So that's the benchmark where we usually go well under that to try and save as much muscle as possible.
Oh, I see. All right. Thank you.
Thank you.
Okay, I think our next presentation is surgical. Dr. Campati is our new sort of lead cardiac surgeon at JPS. He's been with us since 2017, I think, late 2017. He's been just doing a fantastic job, really bringing some of our practices in cardiac surgery into the cutting edge, and he's been a phenomenal contributor here and a great partner to many of us. So, without further ado, I will turn it over to Dr. Campati.
Thank you, Dr. Stevenson, and I'd like to thank the board for allowing us to present this information. Next slide. So, as far as cardiac surgery, the techniques that we use to do surgery are pretty well established for most disease processes, and especially for coronary bypass operations for blocked arteries and heart valve operations. These are very well established as far as how to do the operations and what sort of resources are required and so forth. And so in general, the results of heart surgery are divided into two categories, what we call early, which is within a month of surgery, and then late, which is everything else after a month. And early on in heart surgery, most of the focus was how to do improve things early after surgery, meaning within that first month. Next slide. So over time, now the modern standards in cardiac surgery look to improve the outcomes after a month after surgery. Because obviously, if you're the patient, what happens in the first month after surgery is all well and good, but you really pay attention to what happens after that. And obviously, how long you're going to live for, how good your functional status is in terms of being able to exercise that limitation, avoiding future reinterventions for new problems, and then avoiding admissions to the hospital for problems. Next slide. So I will talk about two areas that we focused on for specific process improvements. The first is atrial fibrillation, which is also called AFib. AFib is the most common heart rhythm problem, and it affects about 2 million people in this country. So most patients have AFib as a standalone problem, and it sometimes coexists with other forms of heart disease, be it weakened heart muscle or heart valve problems. And when AFib exists with other heart disease, it creates more problems than it does as a standalone problem. So when patients present for requiring heart surgery for a heart valve problem or a blocked artery, AFib exists in about 10% of the patients. And so the issue then is treating the AFib. And the physicians' specialty societies in the various specialties have all gotten together and created these guidelines for how the doctors should manage specific problems in patients. And basically, the surgical organization has guidelines, and the guidelines are in a class 1, 2, and 3 as far as how strong of a recommendation it is to do something, meaning class 1 is highly recommended, to class 3, not so much. So in the surgical guidelines, this is a class 1 recommendation, meaning this is a very strong recommendation that we, the surgeons, should be doing these interventions in indicated patients. Next slide. So this graph depicts the use of surgical AFib procedures during other heart surgery. So the left bar is the national average, which is near 50%. And then the right bars are the years 2017 through 2020, where after 2017, we made an active attempt to improve this. And you can see that the active attempt has reached usage levels that are comparable to nationwide levels. Next slide. Okay, so coronary artery disease is the most common problem that patients require heart surgery for. And typically when a patient requires surgery for blocked arteries in the heart, it involves multiple arteries in the heart, 2, 3, 4, whatever. And so there are different ways to do surgery for coronary artery disease. And the most, in terms of, because surgery for blocked arteries involves taking a new blood vessel from some other area in the body and then connecting it to the artery past where the blockage is to create another pathway of blood flow. And we always use arteries that are natural blood vessels, meaning not pieces of plastic from a factory. And the most common way to do this involves an artery on the inside of the chest wall and some of the veins from the legs, and rearranging these to make the bypasses. So the alternative way to do this is to take additional arteries from the chest wall or from the arm instead of the leg veins. And this doesn't change anything within the first, the outcomes of surgery within the first month, but it can help in the long term if the patient gets new blockages in the arteries that weren't there when the patient had surgery the first time. So again, there's a guideline for this as well, that using additional arteries improves late outcomes in younger patients having surgery. And our definition of younger patients is patients less than 70 years old, which is not seem that young, that just isn't that old for anyone. So, and this is from a guideline standpoint, is Class 2A guidelines. This is also something that as the surgeons we should be doing, and we made a specific effort to do that, especially given that almost all the patients who have surgery at JPS are younger patients in this patient population. Next slide. And next slide. Next slide.
Jeffrey, are we having a technical problem?
Yeah, there is another slide after this. There we go. Okay, good. So this is a graph depicting our performance in this area. So the far left is a national average. And you can see, which is actually about 10%. So starting in 2018, we made a specific effort to increase this for the reasons I alluded to, as far as the patient population and so forth. And you can see our performance here is above the national averages in this category. Next slide. So in conclusion, you know, so from a heart surgery standpoint, you know, we will provide the highest quality of care, and looking at nationwide guidelines and standards to achieve that. Thanks.
No, that's great. All right, Chuck Weber here. Are you doing any ablations for atrial fibrillation in heart patients without coronary coronary occlusive disease?
Yeah, so Dr. Demas with EP cardiology does AFib ablations that are for isolated AFib without other heart disease. He is doing those procedures, yes.
Good. It's a nice little summary. Anybody have any questions?
I think it's really notable that Dr. Campati, you know, so the evidence on total arterial conduits for bypass surgery is pretty great data. Actually, it's remarkable how reluctant American heart surgeons have been to embrace it, but Dr. Campati is a real master in this area and has had, really terrific numbers and outcomes from this for our patients. So, in terms of surgical revascularization, our patients here are really, receiving absolutely the gold standard of care for heart surgery, and I think we ought to be really proud about that.
Excellent. Thank you very much.
Thanks.
All right. For our final presentation for Heart Month is our heart failure program. This is really a phenomenal program, and I am very very grateful to Dr. Kamath, who's already been mentioned multiple times during this board meeting today, this committee meeting today, as just a phenomenal contributor in the management of heart failure patients. So without further ado, I will turn it over to him.
Thanks, Dr. Stevenson and Board of Managers, for the opportunity to briefly highlight quality improvement efforts designed at improving heart failure care in Tarrant County and the JPS Health Network. I just wanted to kind of briefly highlight the problem that CHF is. It's a very highly prevalent and highly morbid illness, and 550,000 new cases, and 2 in 100 people between the ages of 40 and 59, 6.2 million patients. And this is a statistic that I think really kind of brings it home. 50% of patients with left ventricular systolic dysfunction, that's defined as anyone with a left ventricle that functions less than 40%, which is normal is around 60 to 65%. We use the term ejection fraction to describe the amount of blood pumped by the ventricle with each beat. If it's less than 40%, 50% of those patients at initial diagnosis will die within 5 years of that diagnosis. And then in Tarrant County, about 200 per 100,000 die each year from CHF, and that comes out to about 4,100 deaths every year. So we see a high burden of CHF at JPS because people are at risk for the development of CHF because of uncontrolled hypertension, uncontrolled diabetes, which leads to silent coronary disease. And then there are also other problems such as substance abuse and then healthcare avoidance that lead to progression of heart failure before it's finally identified. Next slide. So you can see here, this is our inpatient heart failure volume, and you can see that it's pretty consistent around 100 or so patients per month, around 1,200 a year. Next slide. So when I came here in 2012 from the University of Virginia, my goal was to develop a heart failure clinic and work with people at JPS to start a heart failure program. And we developed these goals. And everybody's been talking about transitions of care, and this is a very, very important thing in heart failure. When you develop a chronic medical illness that is life-threatening, it's very, very important that you understand what it takes to manage this condition and how you can potentially make it better. It's important to understand that it's not just the treatment in the hospital that is important. It's important to convince the patient that you need to take care of this and you need to follow up with the heart failure clinic. And so we have a couple of ways we do that. We see patients in the hospital, both my physician assistant, Greg, and I see patients in the hospital. And we also have a team of CHF nurses that will visit with patients and provide education. And this is a way to enhance compliance with post-discharge follow-up. We educate patients to enhance their engagement and foster self-management. And then we use proven therapies that have been shown in medical literature to benefit heart failure in both improving symptoms and survival. And this will lead to reduction of readmissions. We also want to find out, and identify patients that are at high risk of frequent, readmissions and utilization, and try to find out why this is happening and develop creative solutions with interested people at JPS. And in my own experience, since I've been keeping track since around October of 2016, we've found 279 patients in our clinic that have had substantial improvements in left ventricular systolic function, from severe, which is characterized as less than 35%, up into at least mild, which is greater than 45%, with most improving to the normal range. And as I said before, if you're looking at this is adding years of quality and quantity to their lives. Next slide. So we decided to join the AHA Get With The Guidelines Heart Failure Registry in 2019 in order to sort of demonstrate our commitment to delivering quality care for heart failure and having a goal of being nationally recognized. This registry involves 1,242 centers nationally. And the way that it works is each center submits a randomly selected sample of inpatients with heart failure based off of ICD-10 primary codes for heart failure that meet their specifications. Next slide. And so we are assessed on 4 key metrics that are known to impact patient outcomes in heart failure with reduced ejection fraction, which is essentially what I've been talking about. The ejection fraction of the left ventricle is less than 40%. The first one is just knowing that somebody has left ventricular systolic dysfunction. So using an echocardiogram to measure left ventricular function. The second is to prescribe evidence-based beta blockers at discharge. And so clinical trials have shown that 3 beta blockers, and 2 of them available in the United States, have been shown to improve outcomes, namely survival in systolic heart failure. And so we must prescribe these 2 beta blockers. They're carvedilol and metoprolol XL. The third metric is to prescribe an ACE, ARB, or ARNI, which is essentially an ACE inhibitor, which is like a lisinopril, an angiotensin receptor blocker, such as losartan, or the new medicine that has come out called Entresto at discharge. That's another metric associated with improved survival in heart failure. And then lastly, to schedule a post-discharge appointment of some sort for the patient with a date and time, and most of those appointments are in our heart failure clinic. Next slide. This is a graph showing the composite of all of these metrics, and our goal or our benchmark is being greater than 85%. And you can see that we are well above the benchmark for every quarter in 2020. Next slide. This is a graph showing the composite metrics for JPS, highlighted in blue, compared to all hospitals in orange, and then Texas hospitals in gray. And you can see that we are at least the same or better in all of these metrics, which we can be proud of. Next slide. So because of this, for consistent performance and consistently achieving the benchmark for 12 consecutive months, we won the Silver Award, similar to the AMI registry. And it's important to recognize that this is not just getting silver instead of gold. We were only eligible for the silver because we've only been participating for 12 months. Our goal is to continue to achieve these benchmarks and achieve gold performance status with 24 consecutive months of achieving the benchmark, which we hope to do in a year. Next slide. And then, like we were talking about, when you provide quality care, it should show in your readmissions. And this is another metric that's nationally recognized as a performance indicator in heart failure. And as you can see, JPS is consistently below the national readmission. And so with that, I'll stop.
Comments, questions from anybody? Don't see any. I'd like to say, well done.
Thank you.
Once again, this is an area where, you know, truly our patients at JPS are actually receiving better care than patients are across Texas or across the United States. And tremendous credit to Dr. Kamath and to all the folks involved with the Heart Failure Clinic and the Heart Failure Program. Phenomenal hard work, phenomenal results for our patients, and I'm just grateful to all of them. And I thought that these presentations would be a great way to celebrate Heart Month at JPS by showing you just what is going on in terms of cardiac care for our patients here at JPS. So I apologize that the agenda ran a little long, but I think this information is very important for you all to see.
Oh, I agree with you. There's a lot of data here in this book, but it's all quite cool.
I'm going to wear a red tie tomorrow, Mr. Early.
Perfect.
I don't usually do that, but, you know, in celebration of Heart Month, Heart Week, and our great team here, I'm going to do it.
I'm gonna ask my wife if I have a red tie, and if she says yes, I'll wear it.
Yeah, Rick, Robert and I are both red-green colorblind.
Yeah.
So
we won't know. So if Chuck and I wear green ties tomorrow, we're really celebrating Heart Month.
That's right. Okay, well, that's it for the open session. Do we have anything for closed? I don't think we do we?
Not to my knowledge. Sean, did anything come up? Okay.
We do not.
No, sir.
No Sentinel events. Outstanding. All right, then we're done. Entertain a motion for dismissal, go home.
Move for adjournment.
Okay, is there a second?
Second.
Somebody?
Second.
All right.
Thank you, everybody.
Bye.
Goodbye, everybody.